Welcome to Stirring Strength, Perspectives on Mental Health and Addiction. I'm your host, Dean Anderson, and on today's show, I have someone who's been very influential in medicine and addiction medicine here in London, Ontario for the past 40 years, Dr. Martyn Judson.
Good morning.
Good morning. Thank you for being here.
Pleased to be here.
I have been a big fan of watching your career, and you've been very helpful in being a bit of a mentor for me and helping me understand some things.
Thank you.
And I had an opportunity to see you share at University of Western Ontario recently with the addictions theory class, and you had some conversation very specifically about the disease model of addiction. And I know it's something that's passionate to you, and you've been doing some talks out in the community or doing some advocacy work on in and around that, what that means. And I'd be grateful to talk about what that looks like in its simplest definition, and then talking about the impacts that it's having on the community or what that looks like, because I think it's, I don't think that just the general public even understand what it really means, what the implications of it are.
No, they don't. The disease model was really introduced probably in the 50s, and it sort of replaced what had previously been the then current interpretation of what substance misuse and addiction was, which was a moral failing, which obviously caused a lot of stigma and precluded people coming forward for help because they knew they wouldn't get guidance and assistance, but instead scorn and ridicule. And so in the 50s, it was thought that addiction in actual fact was a disease, and work was then being done to study brain changes, and there was some evidence that the changes have occurred as a result of people using substances. And so that's how the disease model, particularly the brain disease model of addiction, sort of took off. And I, as a clinician, I was trained to diagnose diseases and treat them. So when I entered addiction medicine some 40 years ago, I felt I needed to justify the work that I was doing. And I looked at it carefully and thought, well, is addiction really a disease? And at that time I was convinced that yes, it was, because if you look at addiction and compare it with other diseases such as diabetes, cancer, pneumonia, heart disease, addiction has all the criteria that any condition must have to classify it as a disease. For example, a disease must be something that you can define. You can define diabetes, you can define heart disease, you can define addiction as being the perceived need to use a substance despite the negative consequences. So, addiction is definable. There's a universal host. Anybody can get or become addicted. Anybody can become diabetic if all the stars align and that everything, all the factors and influencing factors are there. So it's a universal host. It's a progressive condition. Like all diseases progress. Diseases are potentially lethal. You don't always die from your substance use disorder, but you can get pretty close to it if you don't in actual fact succumb. And finally, diseases are treatable. They're not all curable, but they're treatable. So I was satisfied that addiction meets all the criteria.
Check the boxes.
And furthermore, diseases must have certain properties. They must have predisposing causes. That means things that have influenced the development of that condition. And in addition, that would also include genetics and the lifestyle that you grow up in and what you observe and the availability of substances and how much it costs to purchase your substance of use or misuse in comparison to how much you earn. So there are many influencing or
trauma, mental health,
all of those things. And finally, diseases must have adverse consequences. And we know from looking at anybody who's been using substances for a long time, they have a whole range of adverse consequences stemming from medical. That's what brought patients into my office. But strangely enough, people suffering from cirrhosis of the liver is relatively rare in comparison with the vast number of people who misuse substances. Their problems are sort of mainly behavioral and sort of issues within the family. So, and I should also say that people who suffer from diseases have biological changes, and that's where researchers found these changes in the brain. So again, I can emphasize that a disease meets all the criteria. Addiction meets all the criteria for being a disease, and it has all the sort of properties of a disease. So that satisfied me that I could treat diseases, and including addiction. But over time, I became amazed at the influence of people who are not medically trained. And in particular, there's one organization that does far more for the recovering addicted person than anything else. And those are the fellowships of AA and NA. And I also ran into people who are counselors and therapists and social workers, and they're not medically trained. They know a lot about medical studies, but they weren't actually prescribing drugs, and they had an incredible impact on patients in recovery. So I started to think, wait a minute, this disease model is not right. And the more I looked at it, I saw that it's the medical community, including the researchers in studying addiction, that they have really assumed monopoly of how the disease model is influencing society and how addiction is being treated. And, they've been promoting that addiction is a brain disease. Well, when you look at it, if I was to say that you suffer from a brain disease, you're going to feel that you're less than whole, that you're not quite right. So that's stigmatizing in its own right. So have we really helped people? And I think that we've now reached a stage where people argue it's a brain disease or it's not. Well, that's again is too simplistic. And in particular, when we're trying to introduce policies, and politicians and I think are guilty of this, they want a bite-sized definition of what addiction is and what causes it. And you can't put it into simple terms. If you want me to define everything, what addiction truly is, you got to read a book. I'd have to read a book, and you'll have to read, and realize you can't really define the whole problem. And so you can't tell a politician what policies need to be introduced. But you need to understand that there is so much that goes into the melting pot. And I think that to be on one side of the argument saying, yeah, it's a disease, or on the other, no, it's not, isn't really achieving everything. For example, if we say it's a disease, we can also argue that it's a lifestyle. If you grow up in an addicted family and you observe your parents drinking a lot, then you think that that is normal behavior. And when you realize that you don't have to drink every day that you come home from work, or every time someone sort of says something you don't like, that you have to use a substance, that is relatively rare in comparison with the whole population. So yeah, it's a learned pattern of behavior. It's a lifestyle. It's also a means of coping, as I sort of alluded to just moments ago. And it's finally a reflection of the ills that face society. We know that when countries go to war, that's when there's an uptake in alcohol consumption, and people lose their job. They often revert to using substances. So that's
a correlation to coping and safety when there's a lack of ease in community or safety in the environment or the social constructs that substance use increase.
Yeah, and you're touching on something which is close to my heart, that you can also say that, yeah, addiction is a disease, but just take a look at that word, disease. It really means dis-ease. You're not at ease with yourself. So that might be another argument for saying it's a disease, but you've got to explain the caveat that it's in actual fact more of a psychological problem where people just don't feel comfortable in themselves. And, as people have often said, that people if they suffer from addiction, they can say that they have a hole in their soul. And I believe one very well-known member of the Fellowship of AA, Bev T, really wrote a book saying, which was entitled "A Hole in My Soul," which really is what a lot of people do experience. So you could say that, yes, you do have a disease, but it's really more a state of dis-ease. So I think we've got to recognize that non-medically trained people, non-medically researching people have a great deal to contribute, and don't leave it in the hands of the medical community. In particular, when you understand that medical students aren't educated on addiction. I only became interested.
Let's talk about that.
I only became interested in addiction when I was at university in Manchester. My professor of psychiatry, Neil Kessel, had written a book entitled Alcoholism. So this was the first indication to me that alcoholism must be a respectable condition. If this renowned psychiatrist could write about it. And that was what got me interested in respecting the condition. And then I realized that, in fact, psychiatrists and psychotherapists can go a long way to helping people unravel the problems and look inside themselves, because indeed that's where the solution lies. It's not from taking a drug, which they have the potential to misuse anyway, but instead, if they look inside themselves, that's where they'll see the problems. As the Danish philosopher Søren Kierkegaard said in the 1800s, the problems that are in our soul lies within us. The solution lies within us, but we seem to have ignored that. But indeed, if you can explore yourself and dig deep, and you can go a long way to filling that hole that's in your soul, and that is true recovery. When you look at it also, the number of tablets and medications that are used and prescribed by doctors are all potentially addictive in the main part. Benzodiazepines, many of the drugs which are used for antidepressant, as antidepressants, have abuse potential because they can.
I want to put you up on the ropes here, Doc.
Go ahead.
And I've never asked you this before. Knowing that you did addiction medicine for so many years, and knowing that a lot of it had to do with prescribing, is there a conflict within how you're seeing it now versus your years of medical practice, and how you feel about?
Well, as I was saying,
and I'm sorry for putting you on the spot, but I think curious.
It has been a frustration for me because I was just starting to say that medical students aren't taught very much, and I was about addiction, and I was just fortunate to meet with Professor Kessel, who sort of made me consider that addiction is something worthwhile and should be taught in medical school. But in all medical schools here except I think BC, addiction is not adequately taught. And I call addiction, originally I called it the 4-2-1 disorder, because medical students at Western University spend 4 years in medical school. They used to get 2 hours of teaching about addiction. That was prior to COVID. When COVID came along, my hours of teaching about addiction were reduced to 1 hour. And also the disorder of addiction is the #1 cause of morbidity. Addiction causes more harm to society than cancer and AIDS does combined. But you're given 1 hour of teaching. No wonder most medical students and graduates are lamentably ignorant. Right. And I always used to say, if you have an addictive disorder, you want to stay away from doctors, because the first thing they're going to do is reach for the prescription pad and prescribe you something like Valium, and you're just going to end up switching your addiction from alcohol to benzodiazepines. So I think there needs to be better education, but I've tried to improve the medical education at Western University. Frankly, I have given up. They don't want to know. And when I retired, I was effectively put out to pasture. So I've joined forces with the Department of Psychology, and that's where I find a great deal of satisfaction. And I'm being involved in teaching students who are curious and they're interested and they want to learn. Whereas medical students are not, they don't think that they need to learn too much about it because after all, they know everything, don't they?
Yeah. When I went to school and learned about addiction, there was the terminology of the medical model of addiction, even outside of the disease model or the medical model of something's broken, therefore needs to be fixed. Like a broken leg needs to be cast, or needs to be something done to it. But the thing that's strange about it is when we start looking at the medical model, it's not a repair of something that's ill or broken, it's symptom management, which is not repair. That's just like having a broken leg and the doctor says, well, here, just take a pill and never mind the pain and just, it'll go away, but not casting it or not doing any of the work to change it. It's just symptom management, and that's very ineffective. So the medical model is kind of stepped into, like you said, a psychological space where they go, hey, there's a psychological problem here that needs to be maintained. And we go, oh, we'll do that. And it's like, whoa.
And what the medical community has done has not been very successful. And that's bringing me to my current bête noire, which is these supposed safe supply clinics. When I first entered addiction medicine, I was focusing my work on managing alcoholics. And then I was encouraged by the then Addiction Research Foundation to start prescribing methadone, and I did. And that was at the time of the Percocet crisis. And methadone had just become an experimental drug up in Toronto at the ARF. And it was becoming more widely available in the community. So I opened the first methadone clinic in my general practice office in Whitehills nearly 38 years ago. And within weeks, I just had so many people wanting help to manage their heroin dependence and their Percocet use. So I started to prescribe methadone as a harm reduction strategy, which was very effective in reducing the cravings that people would have if they didn't take their Percocet and their withdrawal symptoms. And if they were prescribed methadone carefully and judiciously, they could be titrated up to a dose that kept them symptom-free from cravings and withdrawal. And that meant they didn't have to spend so much time searching out to get their Percocet. And then it was the rationale that with all that available time when they weren't looking for drugs, they could devote it to rebuilding their lives. In other words, enter recovery, learn life skills, get away from their addiction identity, because that's the only identity they had.
Yeah.
And it worked well. And I recognized that methadone and its successor, Suboxone, which is a much safer drug, by the way, than methadone. So most physicians can prescribe it, and you can't really kill anybody by overdosing on Suboxone, whereas you can with methadone. So I saw that methadone was useful in curbing harm, but it wasn't working for everybody. And I was aware that sometimes to prescribe long-acting drugs like morphine was an alternative to methadone. But the trouble about prescribing morphine is that if you take it, it can still give you a bit of a high, euphoria, buzz. And so, in my opinion, that's not effective. But if you take methadone, it doesn't induce euphoria, and Suboxone certainly doesn't if you're given the correct dose. But then another drastic thing happened. A lot of people were saying that they couldn't tolerate methadone, couldn't tolerate Suboxone, and they didn't want to be on long-acting morphine. And so some doctors wanted to prescribe pharmaceutical-grade opioids instead of addicted people relying on taking short-acting opioids from the street laboratories, which were contaminated with other substances or chemicals which were harmful. And so we started to see a trend in doctors saying, well, what we'll do is we'll prescribe you things like hydromorphone, marketed as dilaudid. This is a very dangerous drug because it's short-acting, it's highly addictive, it causes euphoria. You get that buzz, it wears off pretty quickly, so you go into withdrawal. So what happens then? You want more. So people start to want higher and higher doses, and the more you take, the more harm it does to the nervous system. It destabilizes the nervous system. And as the brain is really the center of all control in the body, you get failings in the immune system, the coping mechanisms, all other organs in the body start to fail, and the body starts to decompensate. But doctors who are prescribing, in my opinion, hydromorphone to compensate for patients who are going into withdrawal, instead of encouraging them to go on to methadone and then ultimately get into rehabilitation and recovery, they're just treating the physical aspect. You're treating the drug, the absence of the drug, by giving more drugs. And then what's made it even worse is that so many safe supply clinics, which were admittedly were introduced to prescribe to pregnant women so that they weren't getting sort of drugs that were contaminated with fentanyl. But then it was expanded to be given to many other patients, not just women, but men. And so we had an uptake in people wanting to be prescribed hydromorphone. And the unfortunate thing, it's kept people locked in their addiction and increasing harm. And patients are not being, this is making it worse, patients are attending these clinics and not getting any encouragement to enter recovery. And I've witnessed it at pharmacies when I've sitting in the pharmacy, seen a patient being given a day's supply of hydromorphone with the instructions to take 2 tablets now and take the others in divided amounts during the day. So the patient walks out with a vial of tablets. Well, we know that one of the hallmark symptoms of addiction is loss of control and inability to abstain. So what does the patient do? They either take all the tablets within minutes, or they're the modern day sort of traffickers. They will sell their supply of hydromorphone to people standing outside the pharmacy, and with that money go and purchase fentanyl, which is even more devastating than the hydromorphone.
So how is the distribution, and I don't want to get into the legalities of it, but more about how's the distribution regulated in the sense of saying, like, could anybody, like, could I go up there and say, even though I don't have an opioid addiction, say, I have an opioid addiction and I would like a safe supply. Could I get prescribed it? Could I just then get the pills and then just, right, and just be like, okay, and keep a stockpile of them and go get my
You
prescription?
probably could. When I first started prescribing methadone, and I was assessing people for their eligibility, as it were, it would be an hour-long interview, and probably then follow up for the next day for a physical examination and some blood tests before I initiated people on methadone, and I would explain the hazards. Now I think you could probably go into a walk-in clinic or wherever some of these safe supply clinics are, which are attached to pharmacies, because there's a financial advantage to that. And you could walk in, and if you've studied DSM-4 or 5, you know what the symptoms are of addiction. When you can go in, and I think you could probably convince a physician who was working there to prescribe you hydromorphone, and you'd walk out within minutes.
There's no biological interface of a drug test or like testing that you have that drug in your system.
No,
there's no brain scan or
there's nothing.
CT that they do to be like, okay, you need this help.
Really,
So
the
it's
diagnosis
really just
of addiction is based primarily
symptom.
on a lengthy interview, not a 5 minutes of assessment. And what makes it worse is that a lot of these doctors working in these safe supply clinics aren't even sitting in front of the patient. They're operating their clinic from their armchair in Toronto, where they can charge a premium for a video link, a system that was introduced into medical practice to treat people living in the far north. But it's been extended to patients who to doctors who can provide that service from another city. We've got many, many competent physicians who know a lot about methadone, who work in London. Many of them worked at Clinic 528. We had 22 doctors working there, but they all met with their patients. We never use computers to interview people. And really recent research has shown that if patients go back and continually see the same clinician, whether it be a psychotherapist or a medically trained qualified doctor, there's that neuroscientific evidence that due to neuroplasticity, there are changes in the brain which enable patients to communicate better and gain a therapeutic relationship with that clinician. And once you've built that trust on the basis of seeing patients regularly in person, the therapeutic alliance is so much more powerful that the patients will, they will establish rapport with their physician, they will engage, they will learn to trust, and they will be captivated by that relationship. And as a result, they're more likely to heed the physician's advice, which should be to rehabilitate, to shed this mantle of an addiction identity. But unfortunately, that's not happening. And you've just got to walk past a walk-in clinic or a safe supply clinic, and you'll see people tragically lolling around, sleeping out there, selling their safe supply medications. It's tragic, and it's time for the regulatory bodies such as the College of Physicians and Surgeons of Ontario and the Ontario College of Pharmacists to step up and live up to their responsibilities to regulate how doctors prescribe opioids, because they, I think, in my opinion, they've been lamentably deficient in doing that. For example, if I was to have prescribed, or if I would prescribe then what many doctors are doing now in terms of prescribing opioids, I'd have lost my license. I certainly did get investigated, because I was seeing up to 65 patients on methadone in one day. My college said, you can't possibly see those patients, that number. And I said, well, my colleagues have gone away on vacation, and I start at 6:30 in the morning, and I stop at 7. I think I can see 60 people. But, I was put through hell because the college didn't know anything about methadone. And seemingly it's the case now. The college doesn't know very much about these safe supplies, and as a result, doctors are destroying my city of London. It's just another loss in this litany of things that we've lost in London. We've lost so much, and we've lost our downtown. So politicians, city council, the colleges, they all need to collaborate and stop lowering the threshold of what is considered a medical entity, and start encouraging patients to face up to reality, be honest, be brutally honest, and start to take responsibility, because that's what recovery is all about. It's not taking more drugs, as you alluded to earlier. It's being honest and responsible, and you find an opportunity to do that in recovery programs. AA, Smart Recovery, the recovery programs that operate down at Epic Recovery, and get away from this insistence on the medical model.
So much information. We've run out of time. I will, throw out there that this is a very complex issue. There's lots of ups and downs of it. There's no way we could encompass it all in 29 minutes talking here today. A lot of people see that there are some benefits of keeping people alive and out of emergency rooms, but at the same time, if you're going to stay down there, you're not really helping the long-term and quality of life in the individual. So there needs to be alternatives to that and what that looks like. And where you can see the crisis that's happening in the city. And I like your encouragement to get people to stand up and talk about it. And the more we kind of push it into the corners, the more it turns into, we make it shameful because we don't want to talk about it. And we don't want to look at what it is. And we kind of pretend like it's not there. And it's not just the physicians or the people with addiction or the counselors, or it needs to be everybody. It needs to be the people as a whole saying, oh, hey, let's all participate in this. And it's not a switch and on or off. It is, how do we negotiate or navigate this in a way that makes it helpful and is in the best interest of, the greater people and our overall health as a community. So I appreciate you being on the show. Thank you so much, Dr. Judson.
Thank you.
And I will chat with you soon. Thanks.
Thank you so much.
Thank you for watching Stirring Strength. We'll see you next time.